Dear friends and colleagues, thank you for attending this webinar on enhanced recovery after surgery combined with outpatient surgery. My name is Pascal-André Vendittoli. I'm an orthopedic surgeon working at Maisonneuve-Rosemont Hospital in Montreal and a full professor of surgery at University of Montreal. I am a proud member of Enhanced Recovery Canada and the chair leader of the Orthopedic Canadian Work Group. This presentation is made in collaboration with the Personalized Arthroplasty Society. Introducing a fast-track protocol in your practice, first you need to set your goals. In the Canadian system, lack of beds availability and improving patient care are our main goals. Secondly, the program may save money to the hospital and it should not include too much new investment. This will impact the way you will build your program and the type of interventions you will select to obtain success. You need to define the type of day surgery program you want to implement. If your main goal is to achieve outpatient surgery alone, this is quite easy. You can select the champions who would leave home whatever you do, or you can let the patient leave the hospital in a wheelchair with a pain pump, a big John's dressing. Doing so, you may increase the risk of complication. And is it exactly what the patient and you want? The real objective of enhanced recovery after surgery is to improve the patient outcome to a level where the patient are ready to go home sooner and safely. So you want to minimize the impacts of surgery as taught by Kellett in Lancet 2013. This is an example of patient who sustained problems after his total knee surgery. Let's listen to him.
You had surgery on your right knee 6 weeks ago.
Coming out of the hospital for the first 24 hours, it was very hard. Hard for me. I had some nauseas. The medication was making me sick. I had some pain, of course, always, and I'm told I had a phlebitis because of the blood and clots and stuff in my legs, so it was really bad. I had hypotension. I had a hard time to move around, and with my cane and stuff was mostly.
Okay. How did your wound heal? Was it healing properly?
I had like an infection, and there was like a discharge coming out of my wound.
And if you had to do the left knee, would you do it right away, or we would wait some time?
When I lived with this one, I'm telling you, I wouldn't do it now. I wouldn't be ready. It was too much to ask.
So this is not a success of orthopedic surgery, and as a patient, this is not the best experience. So to achieve our goal, we first need to identify the potential problems which may affect success. Pain, nausea, orthostatic hypotension, bladder retention, hematoma formation, wound problem, loss of motor function are examples of problems that need to be prevented. Each problem may not occur in all patients, but you need to make the effort preventing all of them. Doing enhanced recovery after surgery, you need to follow the best practices. So developing our enhanced recovery after surgery outpatient protocol, we review the literature to find the highest scientific evidences, identified all the effective intervention you can do at each perioperative period. It is a teamwork. You need the collaboration of all team members. Success of the program depends on the action of each collaborator. If one fails to do his job, it may ruin the effort of the whole group. In our public Canadian system, each professional has full autonomy. Most of them try to do their best, but without integration with the other colleagues' work. There are multiple ways of doing an optimized program. During 2 years, we reviewed the literature and visited other centers of expertise. We had to select all the different interventions to be included in the protocol. Introducing new practices in the medical field is complex. Strong traditions exist. We implemented a specific protocol, like a recipe book, that all caregivers need to follow very tightly. One of the bases of an optimized recovery program, as proposed by ERAS, you need to use a multimodal approach. Each of the potential problems will be prevented by multiple interventions. Each of these interventions may be insufficient independently, but the combination with the other ones will be efficient. This combination of interventions allow reducing the dose, intensity of each specific action, and by the same way, minimizing its side effect. Success of the protocol starts in the office. Patient selection is important, but the goal is to offer the protocol to a vast majority of your patients. Following these inclusion-exclusion criteria, we can include approximately 60 to 70% of our patients in the outpatient enhanced recovery protocol. One of a major hurdle in our area is the lack of family or friend support for the first 2-3 days after surgery. Pre-operative assessment is performed 1 to 2 months before surgery. All modifiable risk factors need to be taken care of. Patients are encouraged to stop smoking and reduce their alcohol consumption if excessive. They are all screened for MRSA, and they are assessed and taught by the physiotherapist. A great option for patient engagement and education is the internet site precare.ca. The patients can find a 10 to 15 minutes detailed video on this site to prepare themselves for their surgery. It is offered in multiple languages and it is very comprehensive for most patients. The day before surgery or early morning, patient will do a chlorhexidine shower. Then they will follow a limited fasting protocol. They are allowed to eat solid food until 6 hours before surgery and drink clear liquids until 2 hours before surgery. We encourage them to take a sugary drink in the early morning, like a clear fruit juice. We also provide the patient a preemptive medication, which include acetaminophen 1 gram, Celebrex 400 milligram, Lyrica 150 milligram, scopolamine patch, aprepitant, which is an anti-nauseous drug with limited side effect and sedation, OxyContin 10 milligram, which will be probably the only opioid used during the whole perioperative period of the patient. In the operative room, at the induction, the patient will receive tranexamic acid 1 gram IV and dexamethasone 6 to 8 milligram IV. The ideal anesthesia method should minimize the duration of motor function loss, should minimize or avoid completely the use of opioid, should minimize or avoid sedation, and also reduce the postoperative risk of orthostatic hypotension. The use of minimally invasive anesthesia is desirable, and the select technique should follow these guidelines. In our enhanced recovery protocol, we selected a modern multimodal anesthesia technique combining an epidural anesthesia with a deep sedation with propofol. This technique is non-traditional and it avoids all opioid use. It prevents all motor function loss. As you can see here, the patient can move his feet during the whole procedure. So if we take on their own the epidural or the deep sedation, they would not be sufficient alone to do the surgery. But combined together, you can do the whole total hip or total knee arthroplasty. In a study by Sajlik in Turkey. They demonstrate that this technique promotes hemodynamic stability, and also it prevents the increase of cortisol and adrenocorticotrophic hormone levels without affecting the insulin and glucose level after total knee or total hip arthroplasty. It was also linked to a reduction in postoperative opioid use and pain reported by the patient. Regarding the surgical technique, we do not recommend special surgical approach. We use in our group a posterior approach for total arthroplasty and a mid-vastus for total knee arthroplasty. You should minimize soft tissue dissection and perform a careful hemostasis. We avoid tourniquet for total knee arthroplasty because many patients complain of thigh pain when it is used. No drains are left in the joint. One of the key interventions for postoperative pain control is the local infiltration procedure. You should use large doses of ropivacaine, approximately 400 milligram, in a volume of 150 to 200 cc of saline. Adrenaline and Toradol should be included for the deep tissue infiltration. Avoiding adding morphine is very important, and using such protocol was proven more efficient to reduce pain in the postoperative period than adductor canal block. And also it prevents any quadricep motor function loss. One very important factor of success or failure of a day surgery protocol is the wound management of your patient. Wound discharge is a major factor of anxiety for the patient, and once at home, in the event of an hematoma discharge, the patient believes they had an hemorrhage. It is one of the main reasons for emergency visit after a day surgery procedure. So we need an optimized wound closure procedure, and I'll present you a method I'm using in our protocol. For the deep fascia closure, I like very much to do a watertight closure with a barb suture PDS1. This suture is barbed and allows to close safely in a running fashion, avoiding making knots. It is a very strong suture that locks itself along the whole length. For the skin closure, I do a subcuticular suture with spiral monocryl. This is a very nice suture. It avoids knots again, and in my experience, it prevents potential stitch abscesses and knot-related complications. It's increased closing speed, and in my experience, it has a lower superficial infection rate versus staples. Over the subcuticular closure, we will seal the wound with a cutaneous glue made of cyanoacrylate plus a mesh. It is branded as the Dermabond Prineo system. First, you apply the mesh over the dry wound and spread the glue on the mesh. Once polymerization is complete, the wound is closed and sealed. This watertight seal creates a barrier to water, bacteria, and also avoid any wound discharge. As I said, there are multiple benefits of an optimized wound closure system for patients undergoing a day surgery. It is a great barrier for contamination. The patient can shower and resume normal life rapidly. There is no staples removal and no related pain or contamination during the procedure of removal. There are no dressing to be changed in the recovery room or at home, and it improves patient satisfaction and reduce the amount of care to be given at home. To reduce hematoma formation in total knee arthroplasty, we use a flexion pillow that we keep under the knee for the first 3 to 4 hours after surgery. We also use cryocompression device to minimize swelling and reduce local pain. A multimodal drug combination is used for the postoperative period. We favor oral drug and avoid subcut or IV administration, even if needed in the recovery room. We remove all catheter as soon as possible. The patient resume normal diet within 1 to 3 hours post-op, and they are encouraged to get dressed as soon as possible. There is no range of motion restriction for total knee arthroplasty or total hip arthroplasty. Here are the medications given to the patient in hospital and to return home. Most total hip arthroplasty are okay with acetaminophen and Celebrex, and they will not take any opioid or tramadol. If insufficient, mainly for total knee, some patient will take tramadol if needed. To prevent DVT, we follow the EPCAT-2 study regime using Xarelto 10 mg for 5 days, followed by aspirin 80 mg for 9 days in total knee and 28 days in total hip. Using a tablet as a drug to prevent DVT is simpler for the patient returning home. When the patient is ready to leave, they will receive an information document and they should have an accompanying person to return home. We provide them an emergency contact number, and they may have a phone follow-up day 1 to 3 post-op and nurse or physio visit if available in their area. We were very successful with our day surgery program. Most patients were very surprised by the impact of the program on their recovery. We received many patient testimonies. We did not expect that the protocol would improve patient function over many weeks that much. Recovery speed looks twice faster than normal, and we had now many patients who had one joint replaced with the traditional method and the last one with the enhanced recovery program. All of them believed that we did a different surgery and say that there is very little comparison between the two experiences. Let's see 2 examples reporting their.
What was mainly the recuperating time. It was just much faster with on the left knee. Like I mentioned earlier, I was walking with a cane probably 5 or 6 weeks after the operation on the right knee, and within a week after the left knee operation, I didn't need a cane anymore. So, and there's virtually no pain in my knee at all.
Did you had to take some pain medication for the left knee?
Yes, we took Tylenol.
Tylenol?
Yeah.
Regarding the physiotherapy, did the physio told you that you were faster with one knee versus the other?
Yeah, the left knee, she said I'm 6 weeks ahead of where I should be right now.
6 weeks ahead of the your schedule.
Yeah.
Okay. You had a problem with the right knee because you were unable to void and to go to the bathroom for more than a day.
Yeah, from the anesthesia, and from the anesthesia on the right knee, I was almost a day and a half before I could urinate, and on the left knee, I was in the afternoon because I was operated on about 11 in the morning, and 3 or 4 in the afternoon, I went to the bathroom.
Okay, good. So for you, the overall, you believe there was some benefit of having the procedure the way it was done on the left side?
Oh yes, no question.
So if you had a third knee, which one you would select?
The left knee. And also only one day in the hospital, it makes a big difference too.
Okay.
Because you rest much better at home.
So you had the left hip done with a rapid recovery protocol and the right hip a few years ago with a standard procedure.
Both recoveries were quite good. However, the new one I just did, it was fantastic. I was ready to go right away. I didn't take any painkillers. After a week for the second operation, I was done with the crutches. I didn't need them. The first operation, I think I was using them for about a month. The physiotherapist that was coming to my house, she was like amazed. Like I was in no time going up and down the stairs, and I had full mobility almost.
Did you experience some nausea, dizziness, hypotension? Okay.
Not at all. I was in great shape right away. Like I had no pain. I literally had hardly any pain whatsoever. My physiotherapy that I did for the month, I was doing everything. No, there was no pain. The progression was really fast. I'd say the rapid was the best experience.
So let's see the result of our first 120 enhanced recovery outpatient cases. We published the result of that study in a journal recently. We compare the result of these 120 cases with 150 patients who had their surgery done in the previous years with the standard protocol. The result of that study can be found open access onto the DOI number you can see here. The same inclusion criteria would apply to select the control group, and you can see that we obtain a 50% reduction of the adverse event rate in the enhanced recovery group, specifically 4 times less of the grade 2 complications. Here are the type of adverse event grade 1 that we encountered in both groups. Pain, nausea, vomiting, dizziness, headache, constipation, hypotension, hematoma, anemia, and lower limb swelling were all significantly reduced into the enhanced recovery program. For example, have a look at the nausea and throwing up rate. We had 25% of our patients who throw up with the standard procedure versus now only 1%. This is a major difference in the quality of care for our patients. Grade 2, 3, and 4 were infrequent for both groups, but we can see a difference regarding urinary retention, significant anemia, and DVT rate, which were lower in the enhanced recovery group. Moreover, in the standard group, we had one severe respiratory depression linked to opioid overdose, which did not occur in the enhanced recovery group, where opioids are seldom used. With our enhanced recovery outpatient protocol, we were very successful at reducing all the complications we wanted to avoid. Our interventions were efficient. Moreover, the enhanced recovery outpatient protocol was very cost-effective. The cost of the protocol were minimal, $326 for each total knee arthroplasty and $222 for each total hip arthroplasty. Looking only at the direct costs, we saved more than $4,000 per total knee arthroplasty and around $1,500 for each total hip arthroplasty. The benefits of an effective enhanced recovery outpatient protocol are very important for the patients. We reduce their complication rate and improve the speed of their recovery. For the administrators, we reduced costs, improved beds availability, and improved the organization efficiency. For us as professionals, we have the satisfaction to do our best for our patient. If you want more information on our enhanced recovery outpatient protocol, please read our recent publication available open access. There are supplementary files also available. Thank you very much for your attending this webinar. I also invite you to visit the Enhanced Recovery Canada and Personalized Arthroplasty Society websites, where you can find valuable information to improve your patient outcomes. See you in the next video.